Usually, when we talk about a surgical diagnosis, there's this, underlying expectation of precision. It feels kind of like engineering.
Right, yeah.
The patient comes into the trauma bay, they've broken their femur, we throw on the table, take an x-ray, and there's that jagged white line. You just point at the screen and say, there it is.
Exactly.
It is binary, right? It's broken or it isn't.
And that binary nature is incredibly comforting for a surgeon. I mean, we like pathology to be visible, neatly categorized, and, immediately amenable to physical fixation. You see the gap, you bridge the gap with titanium.
Yeah, but then you step out of the osteology text and into the world of peripheral nerve injuries and muscle physiology, and suddenly that x-ray machine is entirely useless.
Completely useless.
You can't just take a snapshot of a nerve conduction block. We are looking at a diagnostic landscape that is, quite honestly, murky.
It is the absolute definition of diagnostic muddy waters. And when you are preparing for the FRCS trauma and orthopedics exam, those muddy waters are exactly where the examiners want to drag you.
Yeah, they really do.
They know surgeons are comfortable with bones, so they want to see if you understand the invisible cellular biology that actually dictates patient recovery.
Which is exactly why we are bypassing the housekeeping today and diving straight into the deep end. Welcome to this study session. We have curated a highly focused deep dive tailored specifically for you as you prepare for the FRCS exam.
Right.
We are stripping away the noise to tackle two massive, historically intimidating topics, nerve and muscle. And my role here is to act as your proxy, to drive the pace, challenge the assumptions, and ask the exact questions you'd be asking if you were sitting right across from us.
And my role is to dismantle the underlying anatomy and physiology as plainly and, rigorously as possible. We're not just going to memorize lists today.
No, absolutely not.
We are going to understand the why and the how behind the pathology, because true clinical understanding is really the only thing that holds up under exam pressure.
So let's establish our footing right off the bat.
Yeah.
To navigate this amount of complex data, we need a mental coat rack to hang these facts on. We need a framework.
Yes. We have two organizing ideas that will serve as the spine of this entire session. For the nerve, I want you to picture a cable wrapped in 3 distinct sheaths.
Okay.
And for the muscle, whenever you are evaluating it, you must ask 3 simple questions. Which fiber, how much, and how fast?
I am going to lock that in for you right now so it becomes the baseline for the next hour. I'm going to say it twice.
First.
For the nerve. Picture a cable wrapped in 3 distinct sheaths.
Right.
Again, for the nerve. Picture a cable wrapped in 3 distinct sheaths.
Right.
And for the muscle. Ask 3 simple questions. Which fiber, how much, and how fast? Let me repeat that one too. For the muscle. Ask 3 simple questions. Which fiber, how much, and how fast? So let's start with the nerve anatomy. You really can't understand how a nerve fails under tension until you understand how it is built. So let's build the cable.
Okay, we are going to build this cable from the inside out. Since we are operating purely in the audio space, I want you to visualize this cross-section in your mind.
Right.
Right in the absolute microscopic center is the axon. The axon is the core conducting wire. It is a physical extension of the neuron's cell body, which might actually be located feet away in the anterior horn of the spinal cord. And it is responsible for carrying the electrical action potential.
But an uninsulated wire is, well, it's incredibly inefficient. The signal would degrade or travel way too slowly for human reflexes.
Precisely. The metabolic cost of an uninsulated nerve is just too high. So to make that signal travel at high velocities, we wrap the wire. Wrapped tightly around the axon is the myelin sheath.
Okay.
In the peripheral nervous system, this myelin is manufactured by Schwann cells.
And it isn't one continuous tube of myelin, is it? Like there are tiny gaps along the wire.
Yeah.
The nodes of Ranvier. Mechanically, why do those gaps exist?
Because of a process called saltatory conduction. The myelin acts as a brilliant electrical insulator, preventing ion leakage. But the action potential needs to regenerate.
Okay.
So the nodes of Ranvier are the uninsulated gaps where all the voltage-gated sodium channels are clustered. Instead of a slow, continuous wave of depolarization, the electrical signal literally jumps from node to node.
Wow. Okay.
This jumping saltatory conduction massively increases the speed of the signal while saving the cell a tremendous amount of metabolic energy.
So the core equals the axon, wrapped in the myelin sheath for speed, jumping across the nodes of Ranvier. Now, where do the actual structural sheaths begin?
Right here. We add our first true connective tissue sheath. Around each individual myelin-wrapped axon is a delicate, sort of web-like connective tissue layer called the endoneurium.
The endoneurium.
Yes. Composed mostly of type 3 collagen, the endoneurium forms the actual microscopic tube or microenvironment that the Schwann cells and the axon sit inside.
Okay, let's pause and bundle this up. We have the axon wire wrapped in myelin, and then our first structural layer, the endoneurium, wrapping around each individual axon.
Exactly.
But a nerve like the sciatic nerve isn't just one axon, right? I mean, it's thousands.
Exactly. It's thousands. These individual endoneurial tubes are bundled together into groups. We call these groups fascicles, and each fascicle is wrapped in our second sheath, the perineurium.
The perineurium.
Yes. This is where you need to pay close attention because the perineurium is the most highly tested structure in nerve anatomy.
Why? What makes the perineurium so special from a surgical standpoint?
It serves two critical functions. First, the perineurium provides the nerve with the vast majority of its tensile strength.
Tensile strength. Okay.
Right. It is made of dense, lamellated layers of connective tissue that resist stretch. Second, the cells of the perineurium are joined by tight junctions, meaning it forms the blood-nerve barrier.
Let me drill down on that. The blood-nerve barrier. I mean, we talk about the blood-brain barrier all the time, but why does a peripheral nerve in, say, the leg need a barrier?
Because the microenvironment around the axon is incredibly fragile. If the blood-nerve barrier fails, systemic macromolecules and inflammatory mediators leak right into the fascicle.
Oh, wow.
Yeah, this causes edema, raises the pressure inside the fascicle, and can rapidly lead to ischemia and nerve death. So the perineurium protects that internal environment.
That is a massive exam trap, so I'm going to echo that back, and I'll say it twice for you to note down. The perineurium, the second sheath wrapping the fascicles, provides the nerve's tensile strength and forms the blood-nerve barrier.
Perfect.
Again, the perineurium provides the tensile strength and forms the blood-nerve barrier. Tensile strength and blood-nerve barrier belong to the perineurium.
Exactly. And finally, we bundle all of those fascicles together to create the whole peripheral nerve that you actually handle in the operating theater. This entire bundle is wrapped in the third and outermost layer, the epineurium.
The epineurium.
Right. The epineurium is thick, longitudinal connective tissue. It acts as a shock absorber, cushioning the internal fascicles against external pressure and physical trauma.
Okay, let's synthesize this outside in, visualizing the dissection. I want to repeat this list twice. You look at a nerve in the arm, the outermost layer is the epineurium around the whole nerve. You incise that, and you find individual cables called fascicles. Wrapped around each fascicle is the perineurium, giving tensile strength and the blood-nerve barrier. You open a fascicle, and you find individual axons. Wrapped around each axon is the endoneurium.
Spot on.
I'm going to run that list one more time. Epineurium around the whole nerve, perineurium around the fascicle, endoneurium around the axon.
That's the architecture.
If you only keep one thing, 3 sheaths, endoneurium around each axon, perineurium around each fascicle providing tensile strength, epineurium around the whole nerve.
Now that we have built this incredibly durable 3-layered cable, we can move into the pathology. What happens when this architecture meets, the bumper of a car or the edge of a scalpel?
Right. And this is where we hit the eponymous injury classifications, Seddon and Sunderland.
Oh, yes!
I know candidates stare at these two systems and just looks like a wall of Greek and Latin prefixes.
Right.
But if we stick to the framework, the injury grading is literally just answering the question, how many sheaths have you torn?
That is exactly how you must conceptualize it. Let's map Seddon and Sunderland side by side. Sir Herbert Seddon developed his classification during the Second World War based on broad clinical observations of peripheral nerve injuries in soldiers. He gave us 3 broad categories: neuropraxia, axonotmesis, and neuromesis.
But Sunderland came along later and realized that Seddon's middle category axonotmesis was, well, far too broad for the microsurgical era. We needed better surgical resolution.
Precisely. So Sunderland split nerve injuries into 5 distinct degrees. Let's ascend in severity through Sunderland's 5 degrees, tracking our 3 sheaths as they fail.
Okay, let's do it.
We start at the bottom. Sunderland first degree.
Which aligns with Seddon's neuropraxia, right?
Correct. Sunderland first degree is simply a conduction block. The nerve is anatomically completely intact. No sheaths are torn, the axon is entirely intact, the endoneurium, perineurium, and epineurium are all perfect. The nerve is just not conducting.
But if nothing is torn, chemically, what is stopping the conduction?
Usually it is transient ischemia. Think of a classic Saturday night palsy where someone falls asleep with their arm draped over a chair, compressing the radial nerve.
Oh.
The local pressure compromises the microvascular blood supply to the nerve. Without oxygen, the ATP-dependent sodium-potassium pumps fail, and the nerve cannot depolarize. But because the physical architecture is completely intact, once the pressure is relieved and blood flow returns, the pumps kick back on. You expect a 100% full recovery.
So, first degree, nothing is severed. The wire is whole. All three sheaths are whole. It's just a temporary short circuit.
Exactly.
Let's step up to Sunderland's second degree, which aligns with Seddon's axonotmesis.
Here is where structural damage begins. In a second-degree injury, the actual axon, the core wire, is severed. Because the axon is severed from its cell body, the portion of the nerve distal to the injury undergoes a programmed biological death. This is called Wallerian degeneration.
Let's unpack Wallerian degeneration, because candidates need to understand the cellular mechanism, not just memorize the name. How does it actually happen?
When the axon is cut, calcium floods into the axoplasm. This massive calcium influx activates proteases like calpain, which systematically dismantle the axonal cytoskeleton.
Wow.
Yeah, within days, the distal axon fragments. Then macrophages infiltrate the area to clear away the debris, while the Schwann cells proliferate to form guiding columns called bands of Bühner.
But wait, if the axon is severed and dying back, why is Sunderland's second degree still considered to have a highly favorable prognosis?
Yeah.
Shouldn't whatever force severed the axon also destroy the tube it lives in?
That is the genius of the endoneurium. This type of injury is typically a severe crush or traction, not a sharp laceration. The force is enough to snap the brittle internal axon, but the flexible endoneurial tube, that innermost first sheath, survives intact. The wire is broken, but the microscopic tunnel it lives in is unbroken. Because that endoneurial tube survives, when the regenerating axon starts sprouting from the proximal stump, it has a perfect, intact guide rail leading it straight back to its original target muscle.
So the axon is blind, but it can't get lost. It just follows the tunnel.
Exactly. It recovers orderly and, well, growing at a predictable rate of about 1 millimeter a day.
I'm going to repeat that critical distinction for the listeners. I'll say it twice. In a second-degree injury, the axon is cut, but the endoneurium, the first sheath, is still completely intact. The tube survives.
Yes.
Again, in a second-degree injury, the axon is cut, but the endoneurial tubes survives.
That's the key.
Okay, what happens when the force increases and we hit Sunderland third degree?
Things get messy. In a third-degree injury, the axon is cut, and now that first sheath, the endoneurium, is disrupted too. However, the second sheath, the perineurium, still holds.
So the fascicle as a whole keeps its shape, meaning the blood-nerve barrier is intact, but inside the fascicle, the individual tunnels are just wrecked.
Precisely. And this has profound clinical implications. Because the endoneurial tubes are torn, when the thousands of axons try to regrow, they don't have their specific guide rails.
Right.
An axon that originally went to a flexor muscle might cross over and misroute down a tube, leading to an extensor muscle. This results in synkinesis, unintended muscle movements. That's why recovery in a third-degree injury is highly variable, unpredictable, and usually incomplete.
Now we cross into the surgical realm. Sunderland fourth degree.
Fourth degree means the perineurium is now torn. The layer that gives tensile strength has failed. The only thing holding this nerve together is the outermost wrapping, the epineurium.
Yikes.
Yeah, internally, the nerve is a disaster zone. The fascicles are ruptured. In response to this trauma, heavy scar tissue forms, creating a neuroma in continuity. This dense scar physically blocks the axons from regenerating across the gap. You do not expect spontaneous recovery here.
Yeah.
A fourth-degree injury requires a surgeon to physically excise the scar and graft the gap.
And finally, Sunderland fifth degree, which matches Seddon's neuromesis.
Fifth degree is complete, undeniable transaction. The axon is cut, the endoneurium is cut, the perineurium is cut, and the epineurium is cut. The nerve is physically in two separate pieces lying in the wound bed.
Okay, let's pull back from the microscopic view and look at how this is tested. There are two critical exam dividing lines you must isolate in your mind. I'm going to give you both of them twice.
Good idea.
First dividing line. The line between a first degree and a second degree injury. What defines it? Is the axon intact or is it cut?
That is exactly the distinction. First degree, axon is intact. Second degree, axon is cut and undergoing Wallerian degeneration.
I am stating that one more time. The difference between first and second degree is the axon. First degree intact, second degree cut.
Right.
Now, the second exam dividing line, the surgical line, which grades absolutely require surgery. The line is drawn between third degree and fourth degree.
Yes.
Third degree might recover poorly, but fourth and fifth degree absolutely require surgery. Let me repeat the surgical line twice. Fourth and fifth degree requires surgery. Again, 4th and 5th degree injuries require surgery.
Correct. 4th and 5th degree injuries will never recover on their own because of scar tissue and complete structural disruption. They mandate surgical intervention.
If you only keep one thing, 1st degree neuropraxia is a conduction block with full recovery. 2nd degree, the axon is cut, but the endoneurial tube survives for good recovery. 4th and 5th need surgery.
Exactly.
Which brings up an interesting practical problem. If a patient comes into the clinic with a closed traction injury to their arm, you can't just, look through their skin and see how many sheaths are torn.
No, you can't.
They have weakness, but is it a 1st degree block or a 3rd degree mess? We have to measure the damage electrically.
This is where we rely on EMG electromyography. The EMG timeline after a nerve injury is an incredibly strict, highly tested sequence of events. You must know when specific electrical changes occur.
Let's lay down this timeline. I want the exact time points, and we will repeat the critical numbers twice. Start us at the beginning.
First time point, 7 to 10 days post-injury. At 7 to 10 days, if you stimulate the nerve distally, meaning below the level of the injury, you will start to see reduced amplitudes on the nerve conduction study.
Wait, mechanically, why does it take a full week to see a drop in amplitude if the nerve was severed on day 1?
Because Wallerian degeneration takes time. Even though the axon is cut at the injury site, the distal stump of the nerve remains electrically excitable until the physical breakdown of the axon reaches the very end of the neuromuscular junction.
Oh, I see.
It takes about 7 to 10 days for that degeneration to travel down and fully compromise the distal segment. Once it does, the amplitude drops.
Okay, 7 to 10 days. Reduced amplitudes on distal stimulation. I'll echo that twice. 7 to 10 days. Reduced amplitudes distally.
Yeah.
Again, 7 to 10 days. Reduced amplitudes distally.
Good.
What is the second time point? This is the one that examiners love to track candidates with.
The second time point is 2 to 5 weeks post-injury. This is when the muscle that has lost its nerve supply begins to show denervation changes on the EMG. Specifically, the needle EMG will pick up fibrillations and positive sharp waves.
Let's explain the why again. Why does a denervated muscle suddenly start fibrillating at 2 to 5 weeks?
It is a phenomenon called denervation supersensitivity. Normally, acetylcholine receptors are tightly clustered exclusively at the neuromuscular junction, but when a muscle loses its nerve supply, the muscle attempts to, reach out for a new signal by upregulating acetylcholine receptors and spreading them across the entire length of the sarcolemma.
Right.
Because these receptors are now everywhere, the muscle fiber becomes hypersensitive to any random molecules of acetylcholine circulating in the blood. It twitches spontaneously. Those microscopic spontaneous twitches are fibrillations, and it takes 2 to 5 weeks for those extra receptors to be manufactured and spread out.
So clinically, if a junior doctor sees a patient with a nerve palsy on day 10 and immediately orders an EMG to look for denervation, the result is completely useless.
It is worse than useless. It is completely falsely reassuring. The muscle hasn't started fibrillating yet because the receptor spread hasn't occurred. You absolutely must wait for that 2 to 5 week window to confirm denervation.
Let me log those numbers in twice because it is a massive clinical trap. Denervation changes, fibrillations and positive sharp waves appear at 2 to 5 weeks. Again, fibrillations and positive sharp waves appear at 2 to 5 weeks. Do not rush the EMG.
Essential to remember.
Okay, what is the third time point on the recovery side?
The third time point is 6 to 8 weeks. At 6 to 8 weeks post-injury, if the nerve is successfully regenerating and bridging the gap, you will start to see early signs of reinnervation on the EMG. You will see the appearance of nascent polyphasic motor unit action potentials as the nerve fibers begin to wake the muscle back up.
Okay, so our diagnostic timeline is tight. 7 to 10 days for distal amplitude drop, 2 to 5 weeks for fibrillations, 6 to 8 weeks for reinnervation.
Correct.
Now, let's pivot to the surgical timeline. Let's say a patient puts their arm through a plate glass window. Cleanly transected median nerve. Sunderland, 5th degree. When is the definitive window to surgically repair it?
For a cleanly transected nerve, the definitive repair window is 1 to 3 weeks post-injury.
But hold on. If it is cleanly cut, why wouldn't a surgeon just sew it back together on day 1 in the emergency theater? Like, why delay?
It is a brilliant question, and it comes down to understanding the zone of injury. When a nerve is severed, even by sharp glass, the trauma isn't just at the microscopic slice. The tissue on either side of the laceration suffers microvascular thrombosis and stretch. Over the next few days, that adjacent tissue will die back. If you perform a primary repair on day 1, you are suturing what looks like healthy nerve, but is actually destined to become necrotic. The repair will fail and scar tissue will form.
That makes total sense.
Yeah, by waiting 1 to 3 weeks, you allow the dead tissue to fully demarcate. When you go in for the repair, you can confidently trim the nerve ends back to healthy, bleeding fascicles before suturing them together.
That makes perfect biological sense. Wait 1 to 3 weeks so the zone of injury clearly declares itself. Let me repeat that window twice. 1 to 3 weeks for definitive surgical repair. Again, 1 to 3 weeks for definitive surgical repair.
Perfect.
If you only keep one thing, fibrillations and positive sharp waves appear at 2 to 5 weeks. Reinnervation at 6 to 8 weeks.
Yes.
We have covered a dense amount of foundational anatomy, injury mechanics, and diagnostic timelines, so it is time for our first pit stop to ensure the foundation is solid before we proceed.
Good idea.
Let's run mid-episode recap 1. Listeners, test yourself as we go.
The 3 sheaths. Outside in, it is epineurium, perineurium, endoneurium. The critical exam fact is that the perineurium around the fascicle gives the nerve its tensile strength and forms the blood-nerve barrier.
Check.
Point 2. Injury grading is dictated by the sheaths. First degree is a reversible conduction block. Second degree, the axon is cut, but the endoneurial tube is perfectly preserved for guided recovery. Fourth and fifth degree mandate surgery. Point 3. On the EMG timeline, never rush the test. Fibrillations and positive sharp waves appear at 2 to 5 weeks.
Spot on. Now that we have mastered the general rules of peripheral nerves, we need to apply them to highly tested, specific clinical scenarios. We are moving to the lower limb to discuss a nerve that is notorious for failing under pressure.
We are talking about the peroneal division of the sciatic nerve.
Yes, the sciatic nerve is the largest nerve in the body, running deep down the back of the thigh. But structurally, it is a deception.
Really? How so?
It is not one nerve, it is 2 distinct nerves, the tibial division and the peroneal division, that are merely bound together in one common outer epineurial sheath. They travel together down the thigh until they reach the popliteal fossa behind the knee, where they physically diverge.
And clinically, whenever there is trauma to the leg, it is almost exclusively the peroneal division that takes the hit, right? The tibial division survives, while the peroneal division suffers. Anatomically, why is the peroneal division so incredibly vulnerable?
It comes down to its anatomical environment and its internal architecture. First, the peroneal division sits more laterally and is heavily tethered to surrounding structures, specifically as it wraps tightly around the fibular neck. Because it lacks mobility, it cannot stretch or glide out of the way of danger.
Right.
Second, internally, the peroneal division has fewer larger fascicles and less protective epineurial connective tissue compared to the tibial division. It literally has less internal shock absorption.
Yeah.
So during high-energy trauma, like a knee dislocation, or during severe traction during a total hip arthroplasty, the peroneal division essentially takes the full brunt of the stretch and fails.
So the peroneal division is lateral, rigidly tethered, and lacks internal cushioning.
Precisely.
Now here's the classic exam scenario. A patient presents with a foot drop. Their tibialis anterior muscle is paralyzed. You know the peroneal fibers are damaged. But how do you localize the lesion? Examiners love asking us to pinpoint exactly where along the leg this nerve was injured. Is it a hip problem or a knee problem?
This relies on a beautiful piece of anatomical deduction. The peroneal division of the sciatic nerve travels the entire length of the thigh to supply the muscles below the knee. However, during its journey down the thigh, the peroneal division sends off exactly one motor branch.
Just one motor branch in the entire thigh.
Just one. High up in the thigh, it sends a motor branch to the short head of the biceps femoris muscle.
I'm going to state that twice so it lands firmly in your notes. The peroneal division sends a branch high in the thigh to the short head of the biceps femoris. Again, a branch high in the thigh to the short head of the biceps femoris.
Now apply clinical logic to that anatomy.
Yeah.
You have a patient with a foot drop. You examine the short head of the biceps femoris. If the short head of the biceps femoris is denervated and weak, the injury must be high up in the thigh at the level of the hip joint, because the nerve was damaged before that high branch could even come off.
But if the short head of the biceps femoris is spared, meaning it fires perfectly normally, yet the muscles below the knee are dead, then the injury must be down at the knee level. The electrical signal successfully made it past the thigh, fired the biceps femoris, and then hit a roadblock down at the fibular neck.
Exactly. The short head of the biceps femoris functions as a perfect built-in level detector for sciatic nerve injuries.
So, short head of biceps femoris is denervated equals thigh-level injury. Short head of biceps femoris is spared equals knee-level injury. Let's echo that twice for the commuters. Denervated short head means thigh-level injury. Spared short head means knee-level injury. Again, denervated short head means thigh-level injury. Spared short head means knee-level injury.
Yes, yes.
If you only keep one thing. The short head of biceps femoris is the peroneal divisions. Tell denervated means a thigh-level injury. Spared means a knee-level injury.
That takes us from the trauma of the lower limb right up to the neck and shoulder. We are moving from the distal peripheral nerves to the proximal roots themselves. Pre-ganglionic brachial plexus injury.
Okay, the brachial plexus is that massive web of nerves in the neck and shoulder that supplies the entire arm. When we evaluate a severe traction injury to the plexus, like a motorcyclist landing on their shoulder, the single most important diagnostic distinction we are trying to make is whether the injury is pre-ganglionic or post-ganglionic. What is the dividing line, and why are the clinical stakes so high?
The dividing line is the dorsal root ganglion, which sits just outside the spinal cord in the intervertebral foramen. A post-ganglionic injury means the nerve root is torn further out in the neck or shoulder, distal to the ganglion.
Right.
A pre-ganglionic injury means a root avulsion. The nerve root has been physically ripped out of the spinal cord itself, proximal to the ganglion.
And surgically, why is a pre-ganglionic avulsion considered so catastrophic?
Because it is fundamentally unrepairable. A pre-ganglionic injury occurs within the central nervous system environment. The central nervous system does not have Schwann cells, it has oligodendrocytes. When a nerve is torn in the spinal cord, oligodendrocytes do not form guiding bands of Bunger. Instead, astrocytes rush in and form a dense glial scar. The environment actively inhibits regeneration. You cannot simply sew a nerve root back into the spinal cord. The roots are gone forever.
So as a clinician examining this motorcyclist in the trauma bay, you are hunting for signs that tell you this is pre-ganglionic. The root is avulsed. What are the classic clinical signs? Let's list them, and then I will echo them.
There are 4 classic signs of a pre-ganglionic injury you must memorize. First, Horner syndrome. This presents as ptosis, a drooping eyelid meiosis, a constricted pupil, and the anhidrosis lack of sweating.
Got it.
It occurs because a pre-ganglionic avulsion at the T1 root level simultaneously disrupts the sympathetic nerve fibers that travel right next to the spinal cord before they exit. Second, loss of proximal root-supplied muscles. The serratus anterior and the rhomboids are supplied by the long thoracic and dorsal scapular nerves, which branch off the very proximal nerve roots right against the spine. If those muscles are paralyzed, the injury is extremely close to the cord.
That makes sense.
Third, intractable pain in an insensate or completely numb hand. This is deferentation pain. The central nervous system is screaming because it has lost its sensory input. Fourth, on an MRI or myelogram, you will see a pseudomeningocele. When the root is avulsed, it tears the dura and arachnoid mater, creating a pouch of cerebrospinal fluid leaking out of the spinal canal into the neck.
Okay, I am going to list those 4 devastating signs again twice. Pay close attention. 1, Horner syndrome. 2, loss of proximal root-supplied muscles, specifically the serratus anterior and rhomboids. 3, severe pain in an insensate hand. 4, pseudomeningocele on imaging.
Yeah.
Let's run that list again. 1, Horner syndrome. 2, loss of proximal root-supplied muscles. 3, severe pain in an insensate hand. 4, pseudomeningocele on imaging. But there is one more sign, right? A physical exam finding on the patient's neck, and you warned me this is where the examiner set their trap.
Yes, the bruising clue. When a nerve root is avulsed directly from the spinal cord, it bleeds heavily into the deep fascial planes of the neck. Because of how the deep cervical fascia is arranged, this blood tracks backward. Therefore, a pre-ganglionic root avulsion causes visible bruising specifically in the posterior triangle of the neck.
The posterior triangle.
Yes. The classic multiple-choice exam trick is a negative question. They will ask, which of the following signs is least likely to indicate a pre-ganglionic brachial plexus injury? The options will include Horner's, pseudomeningocele, pain in a numb hand, and then they will slip in bruising in the anterior triangle of the neck.
And that is the trap, because anterior is the wrong fascial compartment. Pre-ganglionic injuries cause posterior triangle bruising, not anterior. Let me state that distinction twice to ensure nobody falls for it on exam day. Pre-ganglionic injuries cause bruising in the posterior triangle. The exam trap is offering bruising in the anterior triangle. Again, pre-ganglionic injuries cause bruising in the posterior triangle, not the anterior, if you only keep one thing. Pre-ganglionic signs are Horner's, loss of root-level muscles, pain in an insensate hand, and posterior triangle bruising, not anterior.
We have spent a lot of time on a nerve as a conduit. Now we are going to bridge the gap between the nerve and the muscle it commands. We do this by looking at the specific interfaces, cutaneous receptors in the skin and the neuromuscular junction.
Let's start with the skin receptors. There are 4 specific cutaneous receptors you are required to know, and the syllabus categorizes them by whether they are slow adapting or fast adapting.
Right, let's break them down clearly. First, we have Merkel cells. Merkel cells are slowly adapting receptors. They're responsible for sensing sustained pressure and constant texture. Because they are slowly adapting and fire continuously while pressure is applied, we test them clinically using static 2-point discrimination. Second, we have Meissner corpuscles. Meissner corpuscles are rapidly adapting. They are designed to sense light touch and flutter. Because they adapt quickly to movement and changes in pressure, we test them clinically using moving 2-point discrimination.
I'm going to pause you right there because swapping Merkel and Meissner under the stress of an exam is a remarkably common error. Let's use a mnemonic to lock this down forever, the M vs. SM trick.
Let's hear it.
Merkel is for constant steady pressure. It is for static 2-point discrimination. Meissner is for moving 2-point discrimination. Meissner and moving both start with an M. Let me say that twice so it sticks. Merkel is static 2-point discrimination. Meissner is moving 2-point discrimination.
A perfect mnemonic.
Again, Merkel is static 2-point discrimination. Meissner is moving 2-point discrimination.
Now for the remaining 2 receptors, which are less commonly confused but equally important. Third are the Pacinian corpuscles. These are also rapidly adapting, but they are located deeper in the dermis and are tuned to sense deep pressure and high-frequency vibration.
Got it.
Fourth are the Ruffini endings. These are slowly adapting, and their primary job is to sense mechanical stretch in the skin, which helps with proprioception and joint position sense.
So the breakdown is Merkel is slow static, Meissner is fast moving, Pacinian is fast deep vibration, Ruffini is slow stretch. Let's run that list again. Merkel is slow static, Meissner is fast moving, Pacinian is fast deep vibration, Ruffini is slow stretch.
Spot on.
Now let's look at the motor interface, the exact point where the nerve terminal connects to the muscle fiber, the neuromuscular junction. We need to discuss a pharmacological agent that acts right here. Botulinum toxin A or Botox.
Yes, botulinum toxin is a vital tool in orthopedics, particularly in pediatric orthopedics, for managing severe spasticity in conditions like cerebral palsy. You are expected to know its exact cellular mechanism of action.
How exactly does it paralyze a spastic muscle?
Botulinum toxin A works at the neuromuscular junction by blocking the presynaptic release of acetylcholine to go a layer deeper for the FRCS. The toxin is taken up into the presynaptic nerve terminal. Once inside, it cleaves specific snare proteins, specifically SNAP25. These snare proteins are required for the vesicles of acetylcholine to dock and fuse with the nerve membrane.
Right.
If the vesicles can't fuse, the acetylcholine cannot be released into the synaptic cleft. No acetylcholine release means the muscle never receives the signal to contract, resulting in a flaccid paralysis.
The absolute key word there is presynaptic. It acts entirely on the nerve side before the synapse, destroying the vesicle fusion machinery.
Yeah.
It does not block the receptors on the muscle. Let me say that twice for the notes. Botulinum toxin A blocks the presynaptic release of acetylcholine. Again, Botox blocks presynaptic acetylcholine release.
Correct.
If you only keep one thing, Merkel is slowly adapting static 2-point discrimination. Botox blocks presynaptic acetylcholine release.
That marks a major transition point.
It does. It is time for mid-episode recap, TWO, before we leave the nerve entirely and plunge into muscle physiology. Let's run the second pit stop, reviewing the clinical applications we just covered.
The short head of biceps femoris is the localizer for the peroneal division of the sciatic nerve. Denervated means a thigh-level injury. Spared means a knee-level injury.
Check.
Point 2. Pre-ganglionic root avulsions are unrepairable. Signs include Horner's, loss of proximal root muscles, pain in a numb hand, and crucially, posterior triangle bruising. Watch out for the anterior triangle distraction.
Here.
Point 3. Cutaneous receptors. Merkel is static 2-point discrimination. Meissner's moving 2-point discrimination.
Check.
Point 4. Botulinum toxin A causes a presynaptic block of acetylcholine release by cleaving snare proteins.
Excellent. We are now officially crossing the neuromuscular junction and arriving at the muscle itself. We are returning to our second core framework. Whenever you evaluate a muscle, you ask 3 simple questions. Which fiber, how much, and how fast?
Let's tackle question 1. Which fiber? We need to differentiate the types of muscle fibers making up human skeletal muscle, type I versus type 2.
Think of muscle fibers as being highly specialized for different physical demands. Type I fibers are your postural workhorses. They are slow twitch fibers.
Okay.
They are highly oxidative, meaning they rely on aerobic metabolism. Because they need a constant supply of oxygen, they possess a rich capillary network and high myoglobin content, which makes them appear red under a microscope. Their defining characteristic is that they are highly fatigue resistant. They are designed for endurance, like holding your spine upright all day.
Type I slow, oxidative, red, fatigue-resistant endurance fibers.
Now, a critical concept here is recruitment, which order your central nervous system turns these fibers on. According to Henneman's size principle, motor units with smaller motor neurons are recruited first because they have a lower threshold for depolarization.
Right.
Type I fibers are innervated by these small motor neurons. Therefore, type I fibers are always the very first to be recruited when you initiate any movement.
So type I equals slow endurance, recruited first.
Got it. Now, what about the power fibers? Type 2.
Type 2 fibers are your trauma response fibers.
Yeah.
They are fast twitch. Type 2 is subdivided into IIA and IIB, or sometimes called I in humans. Type IA fibers are fast oxidative glycolytic. They are an intermediate middle ground, adaptable with training. But type IIB or IIS are the extreme sprinters. They are fast glycolytic fibers. They rely on anaerobic glycolysis. They appear white because they lack myoglobin and dense capillary beds. They contract incredibly fast and generate massive power, but they're highly fatigable. They accumulate metabolites and burn out in seconds.
Fast but fatigable.
Right. And critically, according to the size principle, because they are innervated by large motor neurons, type 2 fibers are recruited last. Your body only fires them up when you demand maximum explosive force.
Let me summarize that spectrum and repeat it twice for absolute clarity. Type I fibers are slow, red, oxidative endurance fibers, and they are recruited first. Type 2 fibers are fast, white, glycolytic power fibers, and they are recruited last.
One more time for the notes. Type I is slow, oxidative, recruited first. Type 2 is fast, powerful, recruited last.
That answers which fiber. Now for the second question in our muscle framework. How much? Specifically, what physical or anatomical property determines how much maximum contractile force a muscle can generate?
Intuition might say it's the volume of the muscle or the length of the muscle belly, or maybe having a higher ratio of type 2 fibers.
Intuition is wrong, which is exactly why it's tested. The single biggest factor for determining maximum muscle force is the physiological cross-sectional area of the muscle, often abbreviated as PCSA.
PCSA.
Yes, you must distinguish this from anatomical cross-section. Physiological cross-sectional area accounts for the pennation angle of the muscle fibers. It represents the total area of all the individual muscle fibers pulling in parallel.
Oh, okay.
A pennate muscle, where fibers attach obliquely to a central tendon like a feather, packs far more fibers into the same volume than a parallel muscle. More fibers pulling in parallel equals greater maximum force. It is not about length. It is all about cross-sectional area.
The physiological cross-sectional area. It's the total sum of the parallel pulling power. I'll state it twice. The single biggest factor for muscle force is the physiological cross-sectional area. Again, maximum force is determined by physiological cross-sectional area.
And this leads us to a highly specific, fascinating bit of pathology that occasionally crops up in the basic science papers regarding muscle atrophy and steroids.
Yes, the steroid fact. This comes from research on immobilized muscles. Let's say you have a patient in a long leg cast after a complex tibial plateau fracture. The muscle is completely unloaded. What happens if you administer anabolic androgenic steroids during that period of strict immobilization?
Well, conventional physiological wisdom dictates that muscle hypertrophies in response to mechanical loading, and it atrophies when unloaded. You would assume steroids require you to go to the gym to work.
Right.
However, studies on immobilized muscle show that administering anabolic androgenic steroids increases both the muscle mass and the contractile force compared to control subjects, even in the complete absence of mechanical loading.
Wait, how is that cellularly possible without loading?
The androgens bind directly to intracellular androgen receptors in the muscle, which stimulates satellite cell activation and myonuclear addition. It chemically forces the muscle to maintain and even build structural proteins despite being in a cast.
So it doesn't just prevent atrophy, it actively increases mass and force without movement. I will repeat that exam fact twice. Anabolic androgenic steroids in immobilized muscle increase both muscle mass and contractile force. Again, steroids in immobilized muscle increase both muscle mass and contractile force.
That's the one.
If you only keep one thing. Type I fibers are slow, oxidative, and recruited first. Muscle force depends most on cross-sectional area.
This brings us to the final piece of our muscle framework, We have answered which fiber and how much force. Now we ask, how fast? How does the muscle actually move a joint?
This segment is all about the terminology of muscle contraction. There's a cluster of terms starting with the prefix iso that constantly trip candidates up during Viva exams.
Let's decode the prefix first to remove the confusion. Iso is from the Greek, meaning equal or same. So these three words simply describe what physical property is staying exactly the same during the muscle contraction. Let's define them clinically.
Let's take them one by one. First, isometric.
Isometric. Metric refers to measure or length. So isometric means same length. The muscle fires, the cross-bridge cycle, and tension builds within the muscle belly, but the joint does not move. Therefore, the overall length of the muscle stays exactly the same.
Right.
Clinically, this is vital for early postoperative rehab. If you have just fixed a fracture and cannot risk joint movement, you have the patient perform isometric contractions, like pushing their foot as hard as they can against a solid footboard. They exert force, maintain muscle bulk, but the joint remains perfectly still.
Isometric equals same like second term. Isotonic.
Isotonic. Tonic refers to tension or tone. So isotonic means same tension. The muscle shortens or lengthens against a constant load throughout the range of motion.
Like lifting a weight.
Exactly. Think of a standard biceps curl with a 10-kilogram dumbbell. The physical weight of the dumbbell does not change. So theoretically, the tension required to move it remains relatively constant as the muscle shortens. Though we know biomechanically the lever arm changes, classically this is defined as constant tension.
Isotonic equals same tension. And the third, which is the trickiest and most heavily tested, isokinetic.
Isokinetic. Kinetic refers to movement or velocity. So isokinetic means same speed. This is a contraction that occurs at a constant velocity, but with variable resistance.
Variable resistance.
Crucially, you cannot perform an isokinetic contraction with free weights. It requires a specialized, computerized dynamometer machine like a Cybex. You push against the machine's lever arm as hard as you possibly can, and the machine's computer instantly adjusts the resistance to ensure your limb moves at exactly the same preset speed, no matter how much force you apply. It allows for maximal muscle loading throughout the entire arc of motion safely. Constant velocity, variable resistance.
I'm going to repeat all three of those twice, because you need them hardwired. Isometric is same length. Isotonic is same tension. Isokinetic is same speed, meaning constant velocity with variable resistance. Let's hear it one more time. Isometric, same length. Isotonic, same tension. Isokinetic, same speed, meaning constant velocity, variable resistance.
Perfect. There is one final pair of biomechanical definitions regarding movement that we must cover, particularly for sports orthopedics and rehabilitation. The difference between an open chain and a closed chain exercise.
What defines the chain? Are we talking about kinetic chains?
Yes, the kinetic chain of the limb. The definition is entirely dependent on the distal end of the limb, the hand or the foot. In an open chain movement, the distal end of the limb moves freely in space. Think of sitting on a machine at the gym and doing a seated leg extension. Your foot swings freely up into the air.
Okay, open chain is free.
Right. In a closed chain movement, the distal end of the limb is fixed against a solid, unyielding surface. Think of a squat. Your feet are planted firmly on the floor and your body moves over them.
And clinically, why does an orthopedic surgeon care if the physio prescribes open or closed chain?
Because it drastically alters the joint reaction forces. Take an ACL reconstruction. If you prescribe an open chain leg extension, the quadriceps fire and pull the tibia violently forward against the femur, placing immense shear stress directly on your new ACL graft. It can stretch or tear it.
Ouch.
Yeah, but in a closed chain squat with the foot fixed on the floor, the hamstrings co-contract with the quadriceps. The hamstrings pull the tibia backward, neutralizing the shear force and protecting the ACL graft.
That is brilliant clinical context. Open chain equals end of limb moves freely, high shear force.
Yep.
Closed chain equals end of limb is fixed. Co-contraction protects the joint. I'll state the definitions twice. Open chain, distal end moves freely like a seated leg extension. Closed chain, distal end is fixed like a squat. Again, open chain, distal end moves freely. Closed chain, distal end is fixed.
That's it.
If you only keep one thing, isometric is same length, isotonic is same tension, isokinetic is same speed, constant velocity, variable resistance.
And with that, we have completed the structural, physiological, and clinical frameworks for both nerve and muscle.
Which means we have arrived at the outro, kicking off with a final lightning round. This is a rapid-fire mental quiz covering the entire depth of the session. I'm going to fire off the clinical questions, and you give me the immediate, single-sentence answers. Listeners, you need to answer these in your head before you hear the response. Let's go. Question 1. Name the three sheaths of the nerve from inside to outside, and tell me which one gives tensile strength.
Endoneurium, perineurium, epineurium. It is the perineurium that provides tensile strength and the blood-nerve barrier.
Question 2. What is the defining anatomical difference between a Sunderland first-degree and second-degree nerve injury?
In a first-degree injury, the axon is intact. In a second-degree injury, the axon is cut, but the endoneurial tube survives.
Question 3. A patient has a nerve injury. What is the exact timeline for fibrillations and positive sharp waves to appear on an EMG?
Fibrillations appear at 2 to 5 weeks.
Question 4. What specific muscle acts as the anatomical localizer for an injury to the peroneal division of the sciatic nerve?
The short head of the biceps femoris.
Question 5. Name a classic sign of an unrepairable pre-ganglionic brachial plexus avulsion, and what is the exam trap regarding bruising?
A classic sign is Horner syndrome. The exam trap is anterior triangle bruising. The real sign is posterior triangle bruising.
Question 6. Differentiate the clinical testing for Merkel and Meissner cutaneous receptors.
Merkel is static 2-point discrimination. Meissner is moving 2-point discrimination.
Question 7. What is the exact cellular mechanism of action for botulinum toxin A?
It blocks the presynaptic release of acetylcholine by cleaving snare proteins.
Question 8. What single physical factor most dictates maximum muscle contractile force?
The physiological cross-sectional area.
Question 9. Define an isokinetic muscle contraction.
A contraction with constant velocity and variable resistance requiring a dynamometer.
Lightning round complete. To sign off, let's reiterate the two simple frameworks that hold all this complex data together. I'll say them twice. For the nerve, picture a cable wrapped in 3 distinct sheaths. For the muscle, ask 3 questions. Which fiber, how much, and how fast? Again, for the nerve, picture a cable wrapped in 3 sheaths. For the muscle, ask which fiber, how much, and how fast.
Before we close out the study session, I want to leave you with a final thought to mull over, one that builds on everything we've discussed today regarding nerve architecture and regeneration.
Let's hear it.
Think about the profound biological reality of Wallerian degeneration. As orthopedic surgeons, we pride ourselves on fixing things. You can spend 8 hours under an operating microscope performing the most flawless, technically perfect epineurial repair. You can align the fascicles beautifully with 9-0 nylon. But ultimately, you must realize you are merely setting the stage. You are just suturing the outer clastic of the cable. The patient's actual recovery is completely out of your hands. It is entirely at the mercy of cellular biology. A microscopic axon sprouting from the proximal stump, crawling blindly down a surviving endoneurial tube at a rate of just 1 single millimeter a day. It is a humbling reminder that in orthopedics, the knife doesn't heal the patient. Time and biology do.
That is a phenomenal perspective to carry with you into the operating theater and into the exam hall. Thank you for joining us for this deep dive. Keep revising, keep trusting the biology, and we will be here for the next study session.